Today, let's talk about emergency or semi-emergency issues with the eyes, ears, nose, and throat. And in that order, let's talk about the eyes and some eye disorders. So, a little anatomy review. Your eye has a whole lot of stuff going on, and with that, there's a whole lot of stuff that can go wrong with it, including with the lens, with the muscles controlling the eye, with the cornea, with the retina, so on and so forth, with the optic nerve. So, just a quick review here of the anatomy of the eye, and now let's get into some eye disorders. First up, and very common, is conjunctivitis, just an inflammation of the conjunctiva caused by infection. Very, very contagious, easily spread from one to the other. Just got some discharge there in the eye because of that inflammation, because of that infection, but easily treated with antibiotics, antibiotic eye drops. Next up, corneal abrasions. Again, very common. Just a scratch of the cornea. Patient will be complaining of pain and probably some sensation that there is actually something, a foreign body in their eye. But pain, maybe like a scratchiness feeling, especially when they blink. If it gets worse enough, you might have a little spasm of the muscles around the eye. So when you look at the eye itself, you may or may not be able to actually visualize the abrasion, the scratch, but you'll definitely see some reddening of the eye, and the patient will be complaining of pain. That'll differ from an actual foreign body in the eye. Patient will still probably be complaining of pain, and that feels like something's in their eye. But when you go to inspect, maybe pull back an eyelid, you can actually see a foreign body. Here, we'll just irrigate the eye, see if we can get that foreign body out. We don't want the patient to be rubbing their eyes, causing more injury, especially to the cornea, causing corneal abrasions. But if we can get the object out just by irrigation, we will. If it's something impaled in the eye, we'll just leave it there, cover the eyes, and let the hospital take care of removal if it's actually impaled in the eyeball. Inflammations of the eyelid itself, very common. Usually blockage of a gland, an oil gland, is what causes it. Sometimes infection. But very common are styes, just a little blocked gland. They may be uncomfortable, may be painful, but if it's a blocked gland, a stye usually goes away on its own. If it's infection, just needs to be treated with antibiotics. Now, retinal detachments are very real emergencies because they can lead to permanent vision loss, and that's where our retina is detaching from the back of the eye. And signs, symptoms, see that flashes of light, or a patient will complain of flashes of light. This would be a reduction in their field of vision. Maybe kind of like a shadow or a curtain type effect. Maybe black spots that are not quite like floaters. They seem like floaters, but they're not quite floaters. And then this blurred vision along with everything. So we've got this retinal detachment. True emergency can lead to permanent vision loss, and we can actually look at the red reflex. And red reflex, if you've ever taken a picture of someone or seen a picture of you, and there's flash photography, and your eyes are red, that's a red reflex. That's the light bouncing off kind of your vascular-rich retina at the back of your eyeball, and bouncing right back to the camera. That's why the camera picks that up. But you can shine a light into the eyeball, and here we see we can very clearly visualize retinal detachment because of that red reflex is only there for half of that pupil. So we see that the retina is at least partially detached there. So we can use that red reflex to help in our assessment. Next up are cataracts. Cataracts are just clouding of the lens of the eyeball. It can affect one eye, can affect both eyes. Usually starts in one. So you've got a clouding of the lens of one of the eyes. It's going to cause blurred vision, double vision. For light sensitivities, they'll have a lot of trouble with night vision. So very common, and especially as you age, increased I guess, risk of cataracts, but just that clouding of the lens, not an emergency, can be handled outside the ED. But if you see a clouding of the lens, those are just cataracts. Now, cataracts are not medical emergencies themselves. Glaucoma, another common condition, can be an emergency. So glaucoma is just a group of conditions affecting the optic nerve itself. But glaucoma, we're looking at increased intraocular pressure, so that vitreous humor. There is just an increase in eyeball pressure inside your eye. So usually start with a loss of peripheral vision. A classic sign is this rainbow halo around your vision. Our care as paramedics is supportive. It's symptom management, but that intraocular pressure will have to be managed. Otherwise, there can be permanent damage to the optic nerve. If you have an ophthalmoscope handy in your back pocket, you can also look into the eye, to the back of the eye, and you might see papilledema, which is a sign of increased ICP, just a swelling of the optic disc there in the back of the eyeball, and you might be able to see little hemorrhages. When you're looking at the optic margins, you'll see a blurring of that and kind of an elevation of that optic disc, showing the swelling right back in there. Something else you might see with your scope might be macular degeneration. First off, patient will be complaining of differences in vision. So it starts a little fuzzy. There might be a blind spot in the center of their field of vision. So that'll be a telltale sign of macular degeneration, is this blind spot right in the center of their field of vision. Noticeable blind spot, dark spot that the patient will tell you about. And then when you look with your scope, you'll look and you'll see that macular degeneration there in the back of the eyeball. And it's categorized as either dry or wet. For paramedics, we're not going to differentiate that much, but if you are looking in the back of the eye, you will see differences. Okay, that's it for the eyes. Let's move on to the ears. And again, just a little anatomy review. From your outer ear into your middle ear into your inner ear, and the structures and really everything that can kind of go wrong with your ears. There are lots of different ear, we'll call them disorders, ear issues that we'll encounter. Lots of blocked canals and just a foreign body in the ear, just like foreign bodies in the eye, foreign bodies in the ear. Tinnitus, or just ringing in the ears. Hearing loss, especially hearing loss that's not due to advancing age. Common infections, common ear infections. And then we'll talk about tympanic membranes, and not only can they be infected, but they can get torn. If you get called out for a foreign body in the ear, know that it's fairly common, especially in kids, younger kids. Typically, we just try to calm them down, take them over to the hospital, because unless it's right there within our grasp in the ear canal, we do need specialized tools to grab that foreign object. So there are specialized tools that we don't carry on an ambulance, but are shaped differently and kind of grab differently depending on the object that's in the ear canal, and they'll handle that in the hospital. Then there's Meniere's disease, which you may have heard of. This is an abnormality of the inner ear, causing both tinnitus, ringing in the ear, and vertigo. So your patient's going to report just differences in hearing loss and sensation, especially pressure pain, vertigo in the ear. So Meniere's is just an abnormality of the inner ear. Then otitis media, big fancy way of saying just it's an ear infection. Right? You got infection, you got some inflammation in the middle ear. So if you take your scope, take a look at that tympanic membrane, you're going to see it red, you're going to see it swollen. Very, very common in infants, children to get ear infections, and very easily treated. Now your perforated tympanic membranes, your torn membranes, which is a rupture of the eardrum. So if you've ever heard of someone saying, I ruptured my eardrum, it is painful, it is sudden, almost always caused by trauma in some way, shape, or form. So just an increase in pressure, some pressure wave goes into the ear, hits that membrane. It's a thin membrane and causes it to rupture. Over time it will heal itself, but there will be some pain that goes along with it and some temporary hearing changes. Let's move on to the nose and things that could go wrong with the nose, especially the nasopharynx and the structures that lie within the nasopharynx and the nose itself. First off, we'll start with our common call-outs for epistaxis, or nosebleed. And nosebleed's very, very common, and come in two broad flavors, anterior and posterior. Anterior epistaxis is your common nosebleed, easily controlled with pressure or packing up in the nose. Posterior epistaxis is it's a bit trickier, cannot be controlled just by pressure, and will need evaluation in the hospital. Specialized tools will need possibly cauterization to get back into the posterior of the nasopharynx. What are we going to do for epistaxis? Well, if it's a common, everyday anterior epistaxis, we're going to position the patient both upright and lean forward. So we're not leaning back, we're not tilting the head back. We don't want blood to go down into the esophagus, into the stomach, and cause irritation that can cause vomiting. We're going to apply direct pressure, try to stop that nosebleed. We can give Afrin, a couple squirts up the affected nostril. Afrin's a pretty potent local vasoconstrictor, so we can use Afrin in the affected nostril. There's even topical versions of TXA that are out there. If your agency has a protocol for it, you can use TXA just topically right there in the affected nostril. There's a foreign body in the nose, again very common with the kids. Typically not serious, does not carry any airway issues with it. So as a paramedic, we're going to inspect, say, yep, there's something up the nose. Again, if it's very easily grabbed, we can pluck it out of there. Otherwise, we'll take them to the hospital, let ENT take care of it with their specialized tools. And lastly, there is sinusitis, which is just a sinus infection, right? So you got an infection inside your sinuses. You've got a few sinuses there in your face, and sinusitis is sinus infections. You're going to feel pressure. I think we've all had a sinus infection at some point, so you feel that pressure, maybe a little bit of pain. If you tap on the sinuses, tap on the forehead, tap just on the bone just below the eye there, that can induce a little bit more pain or discomfort. And very common, very easily treated. Alright, let's finish this up with issues concerning the oropharynx, the throat, and things that can go wrong with that oropharynx area. First off is just common toothache. So toothaches can be caused by number of causes, from cavities to abscesses to exposed roots are very, very painful. So when dealing with toothache, try to track down the cause of it, and then treat the pain as necessary. You can also see thrush, or what's called thrush. Thrush is in a fungal yeast infection on the tongue, and you'll see these kind of like white plaques on the tongue. So that's just a yeast infection. It's a fungal infection and treated with antifungal medication. And finally, let's talk about peritonsillar abscesses. This is not it's not tonsillitis. This is not an inflamed tonsil. This is an abscess right right in front there. So we've got swollen lymph nodes, we've got a lot of throat pain, we've got some fever associated with it, and then you've got this collection of pus like in around the tonsils. So you've got this abscess forming. So we're going to our treatment's going to be supportive, and then refer them to ENT, who may drain the abscess or treat it otherwise. If you have any questions, please let us know.